Hey, I can start? Hello?
Yes, doctor, you can start your presentation.
Thank you. So, hey, good morning, everyone. I'm Suchi Shah, a recent med school grad from India. Here's presenting a short and intriguing case I encountered during my recent clinical rotation, clerkship rotation. And here's hoping I'd be able to share my experience through this presentation. So, a 20-year-old male, just one minute. So a 20-year-old male patient with present medical history of alcohol use disorder came to the OPD with a complaint of weakness in the lower limbs since 2 weeks. He presents with a progressive ascending weakness in the upper and lower limbs over a period of 2 weeks, and he can walk even with support. It started with the left lower limb and then progressed towards to the right, followed by gradual and simultaneous weakness of both the upper limbs. It was associated with bowel and bladder incontinence since 5 days as well. So on examination, patient was fully conscious, alert, and was not able to walk. Vitals, general examination, systemic examination, including respiratory functions, were unremarkable. I'll talk about neurological examination subsequently. Personal history as such, he was struggling with alcohol disorder and was non-vegetarian, consuming all kinds of meat. Family and social history was irrelevant. Neurological examination, the muscle power was 3/5 in all the four limbs. Muscle tone was increased, and there were brisk tendon reflexes in all the limbs. Babinski was positive, and on further examination, there was reduced sensation to pain and temperature below the level of the T1. No significant anomaly was found in vibration, proprioception, or tactile sensation in all the four limbs. So up till now, when I started taking the history initially, Guillain-Barré syndrome was one of my differentials, but the muscle power, increased muscle tone, Babinski, also respiratory function being unremarkable, which obviously is in the later part, but still kind of deterred me from Guillain-Barré syndrome up till now. We did the CT scan of the brain was performed, which also ruled out cerebrovascular accidents or any kind of parenchymal involvement. Also, clinically, he didn't have any seizures which would make us have some mass effect or something. So the patient, we discussed this with the patient, he underwent MRI next day, and we saw the single, well-defined, thick-walled, round, peripherally enhancing intramedullary lesion of the spinal cord, literally at the T1 vertebral body with surrounding edema. So over here, we can see the T1 body peripherally enhancing lesion. And then we did the T2 weighted MRI as well, and some kind of hyperintensity was seen, possibly suggesting cord edema, and maybe granulomatous lesion with the cord edema was up in our head. So at this point, there were a lot of differentials in our mind, including ependymal cyst, arachnoid cyst, neuroenteric cyst, abscess, neurosarcoidosis, could be anything. But we clinched our provisional diagnosis based on the edema and also the clinical MRI features and the fact that neurocysticercosis or cysticercosis in general is common in India. It led us towards neurocysticercosis being our provisional diagnosis. So we discussed our treatment plan with the patient, and generally, this disease as such is pleomorphic in nature. So because generally anything topographic involvement, activity of the disease, and immune response towards a parasite are generally the mainstay or main factors that guides towards a treatment of spinal cysticercosis. Because this patient had compressive symptoms in terms of bowel bladder involvement, spinal sensations being lost, and almost acute presentation of the disease led us to recommend surgical intervention, though patient was apprehensive, but with further discussions, we could take him into the confidence towards that plan. Also, one interesting thing I learned from my attending was not only surgical, but he said that a lot of combining surgical and medical treatment he has seen that there are many satisfactory outcomes to this disease. So we performed, the patient basically underwent midline laminectomy from C7 to T2 vertebra. We saw the swollen spinal cord, did the midline myelotomy, and saw white cystic lesions, which on aspiration showed us clear fluid. So the resected section was sent to the histological examination, which showed cystic structures of the cysticercosis surrounded by inflammatory cells, which you can see over here. This confirmed our diagnosis for neurocysticercosis. Also, we saw tegmentum cuticles, suckers, and some subcuticular aggregates on histological examination. So patient was given oral steroids, albendazole, for 4 weeks, after which he was discharged. Follow-up after 6 months, we saw improvement in the motor function, muscle power improved from 4 almost to 4. The patient was able to walk with minimal support, which was his major concern. He regained bowel and bladder functions, but there was not much improvement in the pain and temperature sensation, especially over the C7 to T2 dermatomes. So the important question, like I asked my attending, was how did that spread to the spinal cord? Because as I read, I could hardly see a couple of cases on it. Not much has been reported. So you can see over here, humans as such, we are definitive host, and I always studied intestinal amoebiasis intestinal teniasis is very common. So we can also get the neurocysticercosis of the brain, which have been reported a lot, but the spinal involvement could be through the blood circulation, and especially because thoracic spinal cord is highly vascular. Most of the cases which have been reported are in the thoracic spinal cord. Also, it could spread through ventricular-ependymal pathway. So what I learned personally through this case as a student was how to lead a tough and healthy discussion, especially when the stigma around the surgery is being involved. And the rare cases like this just adds a burden to it. So I learned a lot how the whole discussion took place, how we convinced him through this for surgery, and how just the whole transition from him not being able to walk to being able to walk even without minimal support. So also, the second learning point for me was using this as an anchor or as an opportunity to motivate, literally motivationally interviewing the patient, even for the alcohol use disorder. And right now, that patient is sober since 3 months, and we hope that he would be able to reap the benefits of that. Thank you.